Brian, what's on your radar?
Well, yesterday I reported on the corrupted process that led to the creation of a bipartisan Medicare privatization scheme that began under Trump and is now continuing under Biden. If you missed that, you might want to pause this one and check that one out first. But a quick summary is that the Center for Medicare and Medicaid Innovation, which was created as part of Obamacare, has the authority to launch experiments that can either improve quality or reduce costs. And under that authority, CMMI launched a direct contracting model that allows healthcare providers to contract directly with Medicare. So I laid out yesterday how corrupted the model became and how some of the companies that could be drawn into it will be more interested in making a buck than making their patients healthy. But today I wanted to stick up for the concept behind the flawed model itself. So the left in general, and particularly when it comes to healthcare, is too focused just on the government spending side. Take student lending, for example. Decades ago, progressives were able to win grants and subsidies for college students. They were able to do the same thing in the GI Bill after World War II. And both times, the subsidies created an entire cottage industry of for-profit universities built for the sole purpose of fleecing both students and the government. The first time, okay, they got us. But how do we let it happen again? It's part of a lack of concern on the left with how policy actually delivers benefits to people. The main progressive goal since 2016, besides a Green New Deal, has been Medicare for all. And by the presidential primary of 2020, we were deep into fantasy land, with even Kamala Harris briefly pretending she was going to end private health insurance. But if Democrats did manage to enact Medicare for all, and even manage to eliminate private health insurance companies, they'd still have the problem of figuring out how best to deliver care. That's politically important because the right would be working immediately to undermine and repeal it. It's important, obviously, from a health perspective because there are lives at stake. And it's important to build faith in the government's ability to actually do something. And I'm not talking about just the left anymore. The rise of Trump has scrambled politics, and he even asked Paul Ryan why they don't just repeal Obamacare and do single payer instead. That, of course, didn't happen, but we're in a fluid place. So even if you're on the right, this is something you should be thinking about. In other words, people need to start thinking about healthcare delivery, not just who's paying the bill. A new article in Washington Monthly by Meryl Guzner is interesting on this front and worth reading. But the gist is this. There are a couple of different ways you can deliver care with private providers. Traditional Medicare does what's called fee-for-service. If a doctor or hospital provides a service, a physical, a knee replacement, whatever, they get a fee. So naturally, physicians move toward the fields that pay the highest fees, and they perform as many of the most expensive services they can. Those are the economic incentives. Another approach is accountable care or value-based care, which says that a smarter thing to do is pay somebody for quality, not quantity. Between those two general models, it's pretty obvious quality is preferable, but the problem is an obvious one. Who defines what quality is? The obvious answer is that you can generally measure somebody's health, and as long as you're keeping people healthy, that's your job and you should be paid for it. But healthy compared to what? We're a deeply sick society, not just mentally, but physically. And what happens is companies game the system and make it look like their patients are sicker than they are, so that at the end of the year, they can show how healthy they are and rake in money. That's why venture capital and private equity funds are flooding into the space, and that's where the problem comes in, because you have well-funded number crunchers whose only job is to game the system and milk Medicare, and they can outmatch the overworked staff at the government. That's the consequence of a public payer and private providers. You can do a better job regulating them, sure, yes, and we should. But what we also ought to do is allow states and cities to set up their own provider networks. Why should private equity and VC guys be the only ones in the game? Vermont already tried and failed to do single payer, and California politicians are pretending like they're going to do it. But immediately, they could set up a network of providers and start recruiting Medicare patients. The beauty is that doctors absolutely hate their jobs now because they spend way more time doing electronic paperwork and fighting insurance companies than they get to spend with patients. Typically, they have 15 minutes for each patient. Many doctors would leap at the chance to make a nice salary and only have to treat patients. Imagine that, paying doctors to treat patients. At the same time, the amount of care given out often isn't the problem. It's the price of that care, the price of that medical device, or the price of that drug. We can't do much about cost if we don't use the power of the government, from negotiations to antitrust to crack down on price gouging. And by the way, abolish Medicare Advantage while we're at it, but that's for another day. Now, for a long time, progressives have been demanding a public health insurance option to compete with private plans. But they could add to that a demand for public primary doctors, too. The problem in the past has been that public hospitals were underfunded and only served means-tested patients. A smarter way to do it is to cover the entire Medicare population and make it like any other provider network, just one that's not trying to pay off VC investors. With their profits, they can open up to other patients. It would take a little creativity, but any state could do this and could tap into serious federal money, which is now going just to investors. None of what I'm saying here is meant to include everything that's possible or everything that should be tried. But what we ought to be doing is thinking more about how we start actually delivering quality care to people, because the bankers and private equity guys are way ahead of us. If I'm right, the public providers will outcompete the private ones because their incentives will be lined up right, and eventually they'll be the dominant model. In other words, we can dream bigger than just Medicare for all.
Very ambitious, Ryan. Very ambitious.
But that's the thing. It's not actually that ambitious.
No,
It's like one little building, rent. There's plenty of space for lease. It'll pay for itself because Medicare pays for it. And pay for itself for the city.
I like what you're talking about, and I like that you mentioned that there is a tendency on some on the left to just throw more money at it, just fund it. All we care about is making sure we get the dollars flowing, when there is not a lot of care and consideration given to the fact that government functions really badly, private entities can function badly too, or usually they function very efficiently at delivering value to the moneyed interest, and we want to try to direct that so that it's beneficial to society. Whereas the public sector is often just this kind of bloated mess that's not doing anything efficiently. So you can't just say, well, we'll just more money, even more money. If you can get creative and tinker with it and find some interesting solution that uses market mechanisms, but we're going to harness it for the public and we're going to use public dollars to do it, maybe you can do even better.
Right. I mean, like the model that some of these private equity and VC firms are building, they're not fundamentally wrong to say that, hey, we're going to hire doctors, nurse practitioners, administrators, and we're going to make their jobs easy. Their job is to treat patients. And then we on the side here are going to hire McKinsey so we can figure out how to suck as much money out of Medicare for doing that as we can. But what the doctors are doing is a good thing, and doctors prefer it. Because then
doctors.
To spend, I think 99% of doctors would prefer to spend 30 minutes with a patient, because it's not as if the time that they're not spending with patients is enjoyable.
Right.
They're just.
But that is the problem. The problem with healthcare right now is you talk to the doctor for 5 minutes.
Right. And the whole time they're punching. They're just like punching stuff into the computer.
Right. That's why these concierge medical services are getting more popular, where you actually. They get you a water with a lemon in it when you go into the doctor's office, and then you talk to sometimes several doctors, and it's you feel like they're actually interacting with you. And
there's no reason that a city like a borough like the Bronx or Queens or Manhattan couldn't set something like that up, or DC or anywhere, couldn't set that up and say, all right, we're gonna do the same thing that we're gonna apply to CMMI, just like these hedge funds did, just like these private equity firms did. But we're going to get the funding.
When I go to the doctor,
and then you can have two lemons, because the patient gets both lemons.
When I go to the doctor, I don't want the lemons. I just want antibiotics. I just go, This is what I think I'm sick with. Please give me these antibiotics. And then they always go, no, you actually just have a cold or a virus or something, and the medicine we have doesn't work for that. So why don't you come back if you still don't feel well in a week? Usually you feel better by then.
Yeah.
And then in my case, it's COVID. Yeah. But not a reinfection, because those aren't real. I don't believe it yet.
Impossible.
I don't believe it.
Looking forward to what's on your radar up next.